So now I'd like to introduce Hugh Seward. Hugh, you have to roll your trousers up before you come here. Hugh works as both a sports and exercise physician and general practitioner in the Geelong suburb of Newtown. For 25 years he was a medical officer at the Geelong Football Club and has served as CEO of the AFL Doctors Association for 15 years. In 2016 he received the award for the Member of the Order of Australia for his national contribution to injury surveillance and prevention in Australian football. This work included involvement with the AFL Concussion Working Party and development of concussion management protocols. Hugh also has an active interest in the promotion of physical activity. He's been presenting already today, he's been working very hard, and he understands how important GP's role is in encouraging activity for our patients and also for ourselves. So he's chair of the Active Geelong, a community-based organisation established with the aspiration to make Geelong the most active city in Australia. Together with the PHN, he's part of the Geelong GP Activity Ambassador Group conducting research into assist GPs to prescribe physical activity. So Hugh's going to speak to us this evening or this afternoon about head injuries and post-concussion management. Thank you, Hugh.
Thank you, Michael. We'll get some slides up, all right, just about there. Now, this talk is about concussion, and I was going to start to say it's a significant issue in our society, concussion. Everyone, particularly in the football domain, talks about it on a regular basis. But if those who got the age yesterday, you didn't have to go far, you may not have seen it, but this is the weekender from the Age, which has a 6-page article on concussion and footballers and what are the long-term, focusing on the long-term consequences. And the reason we worry more about concussion is because of this media focus. It puts a lot more pressure on GPs, and my talk today is about how do you manage concussion when the patient presents a day or so after in your general practice. But with all this fear, there's also growing up this mystique around concussion which makes GPs much more apprehensive. And I want to take some of that apprehension away, because the management of concussion for GPs, it's mostly fairly simple. Most of the time it's simple, and there's a small number that become quite difficult. So what I'd like to do is to progress through the talk, and we'll come up with some significant things, discussion about what is concussion and what you want to find out when the patient walks in, what advice you can give, and particularly what advice you give in the context that if it's an adolescent, they'll have a parent with them who cannot understand why they can't play next Saturday, and you're going to have to work hard to work through that, why they've had 2 concussions, and it might be the reverse. They should never play football again. You tell them, doctor, they can't play football again. So it is quite difficult. So let's get some strategies and some tools that you can use. I have had some assistance with some of my slides from my colleagues. And one of the things that, for those who want an update, it really is just released. So February 2019 is this document, which is supported by these 4 organisations, and on any of their websites you'll be able to get an electronic version of Concussion in Sport Australia, and a lot of what I talk about and tools are in here. So it's a great resource and only just released, and I'm going to refer to that in a few minutes anyway. And actually read you something in relation to some of the fear-mongering that goes on in these articles. So, every good medical talk starts with a definition. And so, let's talk about concussion is a traumatic brain injury from mechanical forces. That is obvious. But it can be directly to the head or the face, or transmitted, particularly in something like a motor vehicle accident where there are great forces. It can be a transmitted force to the brain. And the effects are usually immediate, but sometimes some of them appear a little bit after. and it can evolve, and it's an important part that concussion can change over time. There's usually, and we'll see a couple of videos in a minute, a short-lived neurological impairment which resolves spontaneously, and usually the resolution follows a sequential course, gradually getting better. Sometimes it's quick, sometimes it's fast, but it is gradual. But then there are these people who have this prolonged concussion. We'll come and talk about them and what you've got to do, because you're going to see a disproportionate number of those in general practice, because probably the minor concussions may have been dealt with elsewhere. And we have to point out that there's no changes that you can identify on an MRI or a CT. The role that they play is if you suspect a significant structural injury. But if you don't suspect a structural injury, they're not going to help you, because it's more a functional injury than a structural injury. And of course, as you're sifting through what could have caused some of the symptoms, you have to work out your provisional diagnosis and get it's not explained by other illnesses. And so concussion is a spectrum of symptoms. It's better described as a spectrum rather than a single diagnosis. And on the scale of your brain injuries, it sits in the minor, minimal, and a few of those prolonged or more severe concussions drift into the mild. So I'm going to talk about helping in the consulting room and how you monitor recovery and advice that you'd give them when you see them about return to play. But it can present its challenges, because every concussion is different and it evolves over time, and because there's no perfect test, you can't do a blood test, you can't just do a scan or an ultrasound, it requires your clinical judgment. And one of the issues often in general practice is that if you've come from a sporting area and you've seen or experienced the concussion yourself, or you've seen a lot of it, that makes it straightforward. But you only see it occasionally. It is a bit more challenging for you. But there is no perfect test. And further after that, I do want to go into how to manage the prolonged concussion and when to refer, and to finally talk about some of the concerns about dementia and what's the level of evidence about that. So, you're presented with the patient. They may be an adolescent, maybe a young adult, and usually fit into that domain. What do you want to know? You want to know, what is the mechanism of injury? How did it happen? What were the likely forces involved? It's usually going to be in the sporting field. It may have fallen off a horse, but usually it's a collision in a contact sport. Now, so you need to find out how it happened. What is their recollection? Remembering that there may be a period of amnesia involved, but what can they recall, or what did others say happened, or if they've got their parent with them, get that observer's point of view. And then we'll come to these in a bit more detail. What were the immediate symptoms, and then what's changed over time. Then in your examination, we'll rule out a structural head injury or a cervical spine injury, and that'll be fairly clear that it's probably not one of those if they've come in 2 days later, and assessment of a number of domains. So what I wanted to do then was to take you through now. I've got 3 videos which will run for a short period of time, so you can get the idea of what are we talking about and the forces involved. Thank you. There's no sound, it's just... So this one is to demonstrate they can be just completely unresponsive for a period of time. Now, he's not unconscious, but he's been unresponsive. He's opened his eyes, but he's not responsive. Okay, so can I have go on to the next slide, please, and then we'll do the same. It's just, right, thank you. And this one demonstrates he's been knocked out, but you're looking at, he's unsteady. And this is what the doctor on the field will be looking at. That's fairly obvious he's not right, but it's focusing on this concept that they stagger a bit, unsteady. I'm going to take this a little bit, we'll watch this a little bit longer because he does get up and he's also demonstrating he's not quite right, and we'll come to that again with the next one. Now we might just stop that one and move on to the third. Now, impact is not great, is it? And you wouldn't think twice, but look. So he's just, everyone can see, and particularly those that know him, he's not quite right. It's a really good question that you can ask, and they're waiting to take him through the interchange, which is all a bit awkward here, but they have to do that. But the game stopped. That's right. Thank you. So, yeah. He's certainly not right, and he may well be saying, what happened, and then 2 seconds later ask what happened, and 3 seconds later again ask what happened. Thank you. Well, it'll probably just run to its end. So he wants to get back on the field because he's confused. Okay, so these are the things, we're talking history. Okay, what are you going to ask about? What happened? And just these key points here are the sorts of findings or observations or descriptions that you might need a witness for, but we would then say is definite concussion. And the regulations and rules now in an AFL, I'll every now and then go back to what the AFL sideline approach is. And the doctors at the AFL have access to Hawkeye, which gives them 7 different views of the incident. And they send one doctor out and the other doctor is looking at the incident from all vantage points to look for these things. So when you're taking the history, it's similarly relevant. Obviously, if they lost consciousness or were unresponsive and someone's telling you that, then that was a concussion. If they're unsteady on their feet, as you saw from those players falling over, that is a concussion. If they're uncoordinated or confused, that's going to be a concussion. This is a scary one. And when we've seen them on the field, and it was a long time ago when I first started looking after an AFL team, we didn't know that this was could be just a concussion. I was sitting on the ground and saw to the left side of my vision, the player had moved on to the right, an opponent, a member of the opposite team, fitting on the ground. So my immediate thought was he's blocked his airway and he's obstructed and we've got to do something about it. So I've gone out to help, and the other doctor has got a 100-yard dash to get to his own player, and we put a Goodell airway down because he was still unconscious, thinking that he was obstructing, but in fact it was just a seizure associated with the concussion. And the other thing you might notice, if you see them on the field and they're hit on the head and you're watching the TV and you'll see their arms go up and they're like this, and this is a tonic posturing that you can get in that concussion from that impact, and then it resolves. And then these other symptoms we talked a lot about: don't feel right, can't remember. So they're the definite concussions in your history, but in your probable concussion, and you may hear this, that they were slow to get up. Well, there's all sorts of reasons why you might be slow to get up, but that may make you suspicious if you're watching, or if they're grabbing and clutching your head. These probably aren't so much in your consulting room, but for completeness I'm going to mention them. And if they've had a visible facial or head injury, or they've got this dazed, blank and vacant look. So they're probable concussions. The doctor during a football game has to also determine, were they unsteady on their feet for other reasons? They may have got poked in the eye and they can't see properly, or they may have got a knock on the head and have a little bit of a knock on the ear and just get a brief vestibular effect. So there are other reasons for this. I've laboured that, but now we talk about these symptoms after the incident, and this is going to be more prominent with your patient. And there's quite a range of domains. And if they're talking about this and they've had a head injury, you're really concerned about persisting headache, a long period of blurred vision after the incident. They were felt dizzy, or the dizziness kept coming back. They had nausea or vomiting, or still have those symptoms if you've seen them really fairly soon after it. A sense of, once again, this not feeling quite right, but other terms, dinged or dazed. Often after a concussion, people are quite fatigued and tired and they want to sleep a lot more. They have difficulty concentrating, and this can then drift into a longer term problem. They may not remember the event. So they're the after the event symptoms to take note of. I wanted to point out here that we've got how long does it take to recover, and we've got this. This is the return to play in an AFL database, and at 7 days we've got something like 80% who, or just over 75%, who had gone through returning to play without symptoms and got back to play. And if we go on to the next one, I think, yep, and we get the numbers there. So at 10 days, 90% have recovered and gone through a return to training to be, and these are adults, remember, we're talking about adults. 90% of all their symptoms are recovered in within 10 days, most players. And their symptoms resolved many days earlier. This one is a test that's a computer-based neurocognitive test, which I'll talk about, and that's a little bit slower to respond, but that 10% is these 10% who haven't got back. So I'm demonstrating that recovery by most parameters is pretty good in 7 to 10 days for the majority of people. So can we predict those who are going to go badly? Yes, if they've had a lot of those initial symptoms, the heavy symptom burden, they may be more likely to go on. But also they've noted that people with a pre-injury history of anxiety, depression can have more difficulty recovering. Teenagers take longer, and if they've had a number of concussions, that may take longer. But it's interesting that even if you've been knocked out for a minute, that doesn't mean you're going to be longer in your recovery than if you weren't knocked out. So, how can you be assisted in your consulting room? And I want to talk about this Sports Concussion Assessment Tool. Sports Concussion Assessment Tool, SCAT. It's now in its 5th edition, and it's produced by a world consensus group, the Concussion in Sport group, and it gives you a tool. Now the tool is really helpful if you're looking after a sporting team and the player comes off, but it's got some helpful aspects for when you're dealing with someone in your consulting room, and I'm going to go through those. It should take about 10 minutes to prepare, and this is for medical practitioners. There's a simpler tool for trainers. Importantly, whilst it's a tool and there is some scoring, the scoring is to compare that patient to when you reassess them a little bit later if you need to. At an AFL level, they'll all have their scores done pre-season so that they can be compared, but you don't have that luxury. There isn't a pass or fail, and there isn't a sort of international guideline to be able to say it's similar to, or you're right or wrong. What it does is give you an assessment tool to aid your clinical diagnosis. So it's an 8-page layout. Just you can download it, the SCAT form, and it starts off with an on-field assessment, which you're not doing at the moment, and an initial off-field assessment, and I'll show you some of these things are really useful, and I use them in my consulting room. So this is what really helps. It's got an assessment of their memory and their concentration. I talked about those two things for someone who you're assessing for concussion day 2, day 3, day 5 may have changed. So the benefit of this is it just tells you what to do, and it gives you the structure to do it. So this is just simply, what's their memory like for, can they remember those 5 words, how many of those words they can remember, and then you give them an alternate list of 10 words and come back later and how many of those can they remember. And rarely can you remember 10 of those words sometime later, but what you get the option to give them a score, so at a later time you can refer back to it and see if they improve when you see them later in the week. And here is their digits backwards. So you start off with the 3 numbers, and you give them the numbers, they give them to you backwards, and so on. You work up through 4, 5 and 6. And normal people start to struggle around here, but if their concentration is difficult, you'll note that they struggle even to do the simple recall tasks for you, or the numbers backwards task. So we'll just skip past that one. So as part of your assessment, and this is more off the field for this one, when you're first assessing them, you would give them the symptoms and get them to read it. But by the time they've reached you, that's unlikely to be very helpful. But it's just to remind you to assess their head and neck and their coordination. And then can they do the tandem gait, the drunks walk easily? So they're helpful, but when you're doing it a few days later, this is a better test. And this is the balance function. Now, I'm not going to go into it in great detail because the instructions are there in this 8-page SCAT tool which you can download, and it's a simple clinical test to test balance. We find that balance resolves much faster than many of the other symptoms. So if you're seeing them 2 or 3 days later, their balance is likely to be very good. But it's standing on both legs, closed eyes, single leg closed eyes, and that 1 foot in front of the other. And you count, I think we've got it here, this is the scoring system, and you don't need to take this down, but there are a number of types of errors, and you can, if they start to stumble or fall, if they have to open their eyes. So you then can record it, and in time compare it another week later. But in this document, it also is very helpful because you can either print off, it's all here in a one-stop shop, your concussion injury advice to give to the person. You might just give that to them verbally or print that out and give it to them, which is the standard concussion advice. And then here are your instructions, all there for the tests I've just gone through. So the key objectives of the SCAT tool, there's got some educational components for both you and your patient, and it's assist in evaluating that patient with concussion. It's based on it's evidence-based with expert opinions, and it's been built up over probably now 20 years. And it's an aid to assessment. Once again, not a pass-fail, but it's a clinical tool. Just to talk a little bit more about some of the things you could find, one thing I just wanted to point out, that in those early stages where people are recovering from concussion, it's been measured as being equivalent to someone who's got a blood alcohol content of about 0.05. So that helps you perhaps understand why some of their cognitive capacities, not understand why, but a comparator for why their cognitive capacities aren't up to scratch. And also there's a concern about increased injury risk if they go back, and some of the studies internationally are showing there's there is a higher risk of them getting a musculoskeletal injury over the next 12 months. So we're expecting a gradual return in 7 to 10 days, and we'll talk more about children in a minute. So I'm going to talk now about are there any other things, if this is, I think, probably beyond the standard consultation, but if you want to spend more time or build your expertise in concussion management, there are some other tools that you can add. So there's a simple digital symbol substitution test. In the early days in the football, so it's a row of symbols and numbers, and you just match the symbol to the box, and you get an enormous variety. You give them 90 seconds to do it, and I can remember when we did it as a pre-season. One guy, I had to have a whole new form built from him. He was so good at it, and other people could hardly get past the second line. So there's a great variation. That's helpful. But if you want to go into it in more detail, and certainly there are some commercial programs that are available, cost a few dollars. Cog State Sport is then used extensively in that football domain by AFL clubs, and it's a computer-based, it's like playing solitaire. It's a time reaction test, and there are a couple of different domains, and some concussion-based clinics and GP clinics with a special interest add that to their domain of assessment. You can follow that over time. It has been touted around for sale in various local football competitions, but it's probably best to be done within the medical domain. If you have someone who you want to take this whole neuropsychological testing a bit further, referring to a neuropsychologist is your next step. And out of interest, there are now 3 clubs that do a full neuropsychological test on all their players pre-season, far more sophisticated than what I've described, and that'll take about 1 to 2 hours per player by a neuropsychologist, so they've got that baseline to come back and test them later for long-term effects. So, well, just I want to talk about the return to play. And there are 2 components to recovery. One is the initial period of rest, so physical and cognitive rest. So you may suggest they don't watch the TV, the kids don't sit with their tablet for hours on end. They rest their brain. Then gradually get back into exposure. But then we've got a graduated return program which I'll take you through. So this is a stepwise return. You can see we start with just a little bit of walking, symptom-limited activity, and if you've got a headache, not feeling quite right, you won't do any of this. Once those symptoms settle, you can start to do a little bit of walking that don't provoke the symptoms. And you progress through these stages each 24 hours if there's no return or recurrence of symptoms. So, if once they start to do a little bit of walking or stationary cycling and their headache comes back, they go back here and you wait another 24 hours and try again. And the same with each step. They may not get any headaches, but they get to the actually doing some drills which require a bit of concentration, and they say my symptoms came back, they have to take a step back. I understand that when you're seeing someone every few days, you have to manage how this can be translated into what advice you give. But the principles are that every 24 hours you can make a step up as long as you don't get a recurrence of your symptoms, and if all was going well, so at about day 7 you could return to play. And that's why you see some AFL players now get back to playing within that time. So, from a general practice point of view, be conservative. Be cautious about the return to play, and just out of interest, you'll see there's an extraordinary difference between 2006 and 2015 with AFL players that missed a game. But when they've been auditing all the concussions, what they've found is it hasn't changed much over the last decade. So the number of incidents are similar, but what's changed is how cautious now with our new knowledge and our concerns about avoiding any long-term effects, they're keeping the players out for longer. So the game hasn't become, the AFL game hasn't become no more dangerous, the doctors have become more cautious. Right, for young people it is different. Can I point out that the return to school is the priority, not the return to playing footy the next week or playing basketball. Return to school, that's what parents who are eagerly pushing their kids in the sporting domain seem to miss. Get back to school, that's the key thing, and they may have to be modified. They never return to play on the same day, but it's the same with the adults. And there is a specific SCAT 5 if they're below 13, and those questions that we talked about and those tests are slightly different. And they include either the parent or the teacher in some of those assessments in that SCAT. So the return to play is different for the child because it talks much more about school activities and being much more cautious, gradually increasing their return to school. I think I've got, yes. So these are the sorts of concepts that you may discuss. They may not go to school for a few more days, they may go back on half days. If they've got some sort of assignments, they may need more time to finish. You may have to get the parent to negotiate those things or do it on their behalf. They might find they're very noise sensitive, so keeping away from noisy environments may be helpful. And communication and reassurance from the teacher is always helpful. I'll go on. So what else out there is there to help you? And unfortunately, I said before, there's no good tests. They're exploring this. Functional MRIs are showing some changes, but not to the extent that we can use them to make the diagnosis. There's about once a year, there's a story in the paper about there's a blood test that's come up or there's a saliva test that's come up that's going to be a saviour for this. Well, it's not there yet, believe me. It's going to be a while. So some of these things are showing promising early results, but it's a long time before we believe that will be helpful. It does come back to clinical recovery and clinical judgment. So take-home messages. There's no perfect direct measure of concussion, and you've got to rely on our clinical assessment. And those clinical assessments or indirect measures of symptoms, their symptomatology, their balance, and their cognitive function. And that stepwise return and being conservative. And once again, just to remind you, most recover, these adults, from those knocks that you saw in their 10 days. So, that's the big box, which is really straightforward, but needs your advice and guidance, and the parents need your advice, because their greatest fear is, what's going to happen to my child? They've had a concussion, are they going to be demented? But then there's this group which will go into the ones with prolonged symptoms, and I want to set some, get some understanding around that, and then we'll talk about what are the long-term, possible long-term consequences. So we've now gone from that acute management in the first 10 days. Someone's come back into you 3 to 4 weeks after a knock on the head, right? Got that? We're in a different paradigm here. So they're prolonged symptoms, and they're quite a mixed bag, because there can be some coexisting pathologies and you have to work through this, and I'll give you some examples of that. And there may be some secondary features that there may have some anxiety or depression that is showing its signs at this point. So there are confounding pathologies. So our first step, if we go through this, right, they've come in, they've still got symptoms a month later. Is there some underlying structural damage? And your threshold for ordering some of those tests may be lower by this point. And conventional neuroimaging to look at that, the structural head injury. But there's a low yield because most of them will be from concussion. And as you've MRIs have been around for a long time now, and the more MRIs you see, the more times you get these incidental findings that you have to explain. So always be cautious and be reserved about when you order those tests. The step 2, is there anything in the past history that's significant? And when we look, sorry, I'll go back. When we're looking at their pattern of presentation, have they precipitated a migraine condition? Is it related to their cervical spine? In fact, are their headaches cervicogenic? And this gets a bit more complicated, but the balance and the oculomotor deficits, I'll talk a little bit more about this, but basically think assessing someone for vertigo. And they may be describing the fact that they're dizziness. And you almost put on, I'm now going to look at those vertigo symptoms, the Apley test, and seeing whether they get their nystagmus. That comes into play here because the concussion may have produced that. And the visual effects, accommodation, their ability to, your convergence points about here, and that may have drifted out in these prolonged concussion cases. So that's another feature you may like to consider. But this is now getting quite complicated, and I don't expect you to remember all this or to put all of these into place, but to know that there are more complexities in your assessment when you're looking at the prolonged concussion. And it comes down to this multimodal assessment. We'll try to get some brackets around it. So we've got your comprehensive history and looking at the symptoms and understanding what is still going on. And because depression and anxiety, if it's some months later, perhaps some of your depression questionnaire may even be relevant here. Then your physical examination, and we're going to look at you're going to do a neurological examination, but then focus on their cervical spine and their balance function, think vertigo, and as you just do the simple watch my finger, sometimes they actually have this saccadic rhythm where their eyes follow your finger like that in some of these symptoms. That can all be retrained and repaired, but that can also be producing some of their difficulties reading and focusing either at school or at work. So look at their neck, think vertigo, think focus, and then autonomic dysfunction. There are some who actually get a postural hypotension because of that autonomic effect. So we're in this difficult domain here. So there are some special tests. The exercise physiologists often do that exercise test looking at their exercise tolerance, and then we talked about sending them off to the neuropsychologist. And this is where the concussion clinics, Epworth here and Epworth in Melbourne, have a really good concussion clinic for that difficult patient I'm now describing. When they've still got their headache a couple of months down the track, they're still feeling dizzy, they've still got ringing in their ears, and you do those tests and you find some changes, you can manage it by picking off those various specialties or choose to send them off for one of the concussion clinics. And they would then include those skilled practitioners. Are there investigations? There aren't really in the area that we have. There's a functional MRI that they're for, I think 7 years ago we thought this might be the answer, that we would put them in this high, very sophisticated, a couple of the universities have these for measuring the brain, and they notice changes in all these pretty colours in there when they do these functional MRIs, changes in concussion, but that hasn't, despite intensive research, really been able to give us a everyday test for our patients. So these are the domains. Multimodal treatment. I talked about the physiotherapist may help with the cervical spine, the cervicogenic headaches. the neurophysiotherapist with those special interests in vertigo, the neuropsychologist for their assessment and brain training, the psychologist if you feel that depression, anxiety and CBT can be a helpful thing for some of these people after their prolonged symptoms. And the exercise physiologist comes into play here with a graded exercise program, and I mentioned a behavioural optometry for this accommodation training, and they use prism glasses. Gets very complicated. So identify, test any of those pathologies that I've mentioned. Now, what I want to point out here, the benefit of further rest is limited. We talked about in the acute phase a few days of rest, but when this prolonged concussion, getting back into a gradual exercise program has been shown to be of benefit to aid recovery. And they exercise within a sub-symptom threshold. And it's probably more for the exercise physiologist, I suspect. The potential long-term complications, what I'm just going to focus on in a minute is the possibility of cumulative damage. And it's come from where the dementia pugilistica, the boxers were getting punch drunk, and they identified the increased deposition of the tau protein. I don't know whether any of you saw the movie Concussion with Will Smith, but those who did, it was about Dr. Umalu, who found tau protein deposited in the brain of an ex-NFL hero who died, and he died of, he developed dementia. It's become incredibly controversial around the world. Christine McKee in Boston has developed then a whole case series, and she's going backwards. So she's got brains with the deposition of tau protein, which is this CTE, and going back and interviewing to find out how many had concussion, and found that a lot of them had concussion. The question is, what does that mean for all the people out there playing football? If she was right, then all old and retired NFL footballers should all be demented and have CTE. And there's certainly some concern about, but there's a passionate group of almost they're vigilantes about the fear of CTE, and we're trying to push back and say, well, we really need good evidence, because the fear-mongering is causing a lot of, we believe, unnecessary concern. But if you say that publicly in their domain, they would say I think in this article, one of the Australians is described as a flat earth person. So anyway, I'm getting near the end, but instead of talking about that, I'm just going to read from this document what is the position on CTE in an attempt to answer where is the evidence going. And I'm quoting, "The link between sport-related concussion and CTE is based on low-level evidence. Research is limited to case reports, case series and retrospective analyses which cannot adequately determine causality or risk factors. The potential contribution of confounders such as genetic predisposition, psychiatric illness, alcohol and drug use, which of course is a high incidence in some of, particularly in that cohort of NFL players, and coexisting dementia is not adequately accounted for in the current literature. While there is significant concern about CTE and its possible relationship with concussion, it's important to note that no causative link has been clearly established." So that's the conservative opinion. And we have to manage that in this domain when we get lots of hype. And there is a legal aspect to this, because there are lawyers, and this article is about the lawyers who are picking up a cohort of AFL players that they think will bring a fistload of money home if they can find that the AFL was negligent. So it's a murky field that we're stepping in, and I'm not going to go into my slides anymore, because I think we've covered that enough. So I'm not going to talk about when to retire because that's really beyond the scope of what our time. So finally, just to talk about the role of protective equipment, because you'd think that if you get concussed because you got hit on the head, put on a helmet and you'll be better. But the forces in a contact on a football field are quite different from when a cyclist is knocked off his bike and bounces on the ground. So bike helmets and bicycle helmets are not the same here, because if helmets made the difference, why does NFL, American football, have such a problem with concussion? So we don't think that helmets have been yet shown to reduce the impact forces. There are some players who use helmets and or using headgear, and it's fine that they do, but I did note that the St Kilda player from this area, McCartan, who's had a number of knocks, got concussed again wearing his helmet, so it was headgear. So it's not stopping the concussion, and it may be that they can find something and they continue to work on it, but not yet. Mouth guards, great for producing injuries to the face and the teeth, but not for concussion. So that's the end of my talk, but I'm happy to take any questions. I've gone perhaps a little bit longer than I'd anticipated. John.
Fitness to drive after a concussion.
Mm-hmm. Right, well, I think it depends on all the resolution of all of those symptoms, and they can drive as soon as they've got good vision, their concentration is good, and their memory is recovered. There's not a rule, it's symptom-based.
Have you noticed any difference between those who are experiencing, say, anterograde amnesia versus retrograde, as in the degree of memory loss? Is that when what they remember, as in they
Yes.
remember before or after?
Yes. So the degree of amnesia doesn't predict a more severe or prolonged concussion, but the amnesia does improve over the days after the incident, but often they're left with a period of 5 or 10 minutes, and it might be the amnesia prior to the incident, or it might be a degree of amnesia after the incident. So that can be there forever. It does improve in time, but it's not a predictor of the severity, but it can be a guide for improvement.
I know you were talking more of GP afterwards, but I'm involved with a football team an hour and a half from Geelong. Which
Match day coverage?
pardon?
Match day coverage?
Yeah, that's my home match. If somebody has a concussion, how do I decide which ones I need to send to Geelong to have imaging on after the event?
Yeah. So first of all, I apologise. I didn't attempt to talk about what you do on the field, but really that's what the earlier parts of the talk about. It's just protecting the neck and if they're lost to consciousness. I think that if you think that there's a potential for a structural injury, and if you think that they might have had a subdural, you send them off. And the worry is that they might then have a slow leak, which they get then appears more during the night, and then they lose consciousness. But there's probably not much to be done in the way of imaging unless you thought there was a structural injury. And so if you thought that my guide would be, if you feared there was a structural injury, or if their condition deteriorated instead of continued to improve, you expect it to keep getting better. In 15 minutes they'll stop asking you for the 50th time what happened, and they'll gradually pick up. They might still have a headache and they might still be not feeling quite right, but they'll be better than they were when they came off, and they'll be better than they were 5 minutes after they came off. And if they continue to improve, I think you can watch them. But if they start to change, or they become nauseated or start to vomit and you can't stop that, then you would consider sending them in. Those two going in the wrong direction from an improvement point of view, and if you think there were signs there that you feared a structural injury. Yeah. I think if they were unconscious for more than a minute is another reason for sending them on. And not many footballers are really unconscious for more than a minute. Even though they look as if they might not be moving. You saw from that video, one of them, where he had his eyes open, he was actually conscious, but he wasn't. You'd think from the boundary he was unconscious. Does that?
Yeah, that's good. We don't have the 7 views, of course.
No. And so you notice I haven't said anything about really seeing what happened. It's just what you're seeing about the player. Because I spent my entire football looking after life having no access to vision. It was just what you saw or what you're told, so I know you are. Joe?
Back to that amnesia, you said that they can be, the amnesia will contract to a residual, possibly 10 minutes anterior or retro. What's the longest that you've seen in your experience in the amnesia? What's the longest period?
I think probably hours, that they can never remember going to the ground or never remember leaving home on that day. And for the severe, really severe ones, they won't remember the game or going to hospital, but that's not common.
Just a question on, I was just wondering if you believe that the resolution of function or return to function actually correlates with the resolution of the injury, to the brain injury. We're assuming that the function return heralds the fact that things be improved, back to normal. Having worked in the area for 30 years, I'm not convinced that return to normal is functioning. And that's pretty gross testing.
So I think it's a really good question, and I don't have the complete answer, and I think this is where a lot of our understanding is going to improve over time. I'll just take you to what I showed you in that slide, and that neuropsychology testing, which they were doing on this sort of solitaire game they do online to check their time reaction test, is slower than their symptom recovery. And so and it's probably for that reason we're saying for the teenager, be far more cautious. I don't believe an under 18 person should be attempting to play the next week. I think that's where you would say you have a week off, even though they will have recovered, just to have that extra caution. And so the take-home message there is, you're saying you doubt that they're recovered even when their symptoms are better, and I would be inclined to agree with you. I think we have to be really cautious. That's what you're alluding to. And I think as some in the future will be able to test and see much more what the cognitive function's like, but at the moment we're dealing very much on a clinical signs and symptoms. It is, yes, yeah. There's a couple in Geelong, and I've forgotten her name now, but and they do. There are a lot of them in Melbourne, I know, but if you need one, I'll try and remember the name of the one I've been using recently. But if you're at that stage where you want a neuropsychologist, you might be thinking about a concussion clinic like the Epworth, and they will have them. They do.
And Grace McKellar has a neuropsychologist,
yes,
but not necessarily that accessible, but certainly someone you could talk to, I'm sure.
It's a good point, yeah.
I'm just saying Grace McKellar has a neuropsychologist who I'm sure could give you some direction as well with who's available in the private system.
Because they deal with that severe head injury and severe head injury recovery with the neuropsychologist, so that would be a good source.
It's a very long wait
Yes, it is. Yes.
But sometimes a phone call, you could at least know where else. There just might be some other options you could
Yeah,
suggest.
you are going to be using it when you're really concerned about long-term symptoms. It's not a short-term thing anyway.
Right. Well, thanks very much, Hugh.
Thank you.